Hi, everyone, and welcome to the second session of the Digitodontics webinar series. This is Mahmoud El-Bashti with you today from Digitodontics International Academy. It's our pleasure and honor to welcome our guest speaker, Dr. Malik Hudieb from the Jordan University of Science and Technology, Jordan. Dr. Hudieb will share with us his experience in virtual dental implant planning, a tool to select your implant design. Dr. Malik Hudieb graduated from the University of Jordan with the BTS degree in 2004, and from Tokyo Medical and Dental University with the PhD in oral implantology and regenerative dental medicine in 2010. He has several granted patents in the field of implant dentistry. He joined the Jordan University of Science and Technology since 2012. Currently, he is an associate professor at the section of periodontology, running several training courses in oral implantology and bone regeneration field, along with several research projects concentrating on the biomechanical aspects of oral implants and alveolar bone using the finite element method. So just before Dr. Malik starts, I would like to raise your attention to start writing your questions on the Q&A part, and then after Dr. Malik finish his webinar, he will more than happy to answer those questions. So without any delay, I would like to welcome Dr. Malik with us today to share with us his experience in the virtual dental implant planning, a tool to select your implant design. So Dr. Malik, I think the stage is yours. Please share your screen.
Okay, thank you so much. Assalamu alaikum, first of all. Evening, everybody. Kompanwa, minasama. Thank you so much, Dr. Mahmoud, again. Thanks to Digitodontics. Thanks for everybody attending this seminar today or webinar today. I will just talk about some logical points in the dental implant field, how to connect things together. My screen is shared or not yet. This one, this is mine, and here is the to start with. Thank you so much. Thank you so much, Dr. Mahmoud. Again, thanks for everybody attending this webinar. It will be always my pleasure actually to share some points regarding the implant field and regarding this new topic actually, virtual dental implant planning, a tool to select your implant design. Whoa. Right. Starting from the implant dentistry, you can know, of course, you know with me that there's many topics in this field, many juice sacks as in this orange exactly. I was eating today many oranges, Dr. Mahmoud. I have some kind of flu. So I was looking to this segment. You see, it is triangular in shape. It's exactly as what I will discuss today. Keep in mind, this seminar will be the orange seminar. Next week, after 2 months, 3 months, any of the colleagues who listen to me, when we talk about the orange seminar, it will be this one. Now, I just would like to sit in this way, and that's all. Yes. Low system resources. What's this again? Okay. Right. Here's the point. Dental implant now, always when we would like to talk about a large field or a small field, we would like to start from the basics, dental implants, yeah? And we have to plan for our dental implants again, yes? We have many kinds or many ways to plan for our dental implants placing or our surgeries. One of them, or one of the recent, recent ways is the virtual planning. Virtual planning, if you look with me, and I like to always to use this way to measure the interest of the institutes worldwide regarding certain topic. I like always to use the PubMed to check with me here, virtual dental implant planning as the title abstract. And with other words, I found here maybe around 690 results, okay? If you check with me again, I like to see these figures always, and it's going up. So I can say, or I can tell everybody that there's an increasing interest in this topic, virtual implant planning. Within a few years, we will not find this diagnostic wax up we continually do in our labs. We will just use the virtual implant planning. So I advise everybody working in the implant field to concentrate on this topic actually. Yeah, here's the virtual planning as I imagine actually, as you know, we can start from our imports from the CBCT, for example, which describes the bone, give me the dimensions of the bone, the digital scanner, whether intraoral or extraoral, yeah, which can give me an idea regarding the available bone, okay, and of course the opposing arch and the occlusion. From the available points, I should go to the dimensions, to the let us say vital structures, to the quality and density of the bone, and if there's any pathology, periapical lesions around, or any problem I can see. Then after checking this, we have to make the decision. Yeah, decision for what? For the two most important points, the implant angulation and the entrance point. Entrance point means where you will start drilling in the implant, in the bone, okay? And finally, the implant dimensions, we can choose it. From this, we can start or go directly to the virtual placement, okay? Virtual placement of the implant, you can imagine and you can put your implant in the virtual bone, which you build from the CBCT. All this requires many softwares we have actually. In this seminar, I will not mention any software and I will not mention any implant type, okay? As let us say commercial types, it will be always your choice as a dentist, as a doctor, to choose your software and implant type, okay? Just we will talk about the principles in this. After this, we might go for the surgical guides, which might need 3D printer or other devices or machines or things or equipments you might need them to go for the surgical guide. This is just a short list of what we discussed now. Here's the CBCT, okay? CBCT actually, something very important, you know, with me, as CT images. Most important thing is to check the buccolingual dimension of the bone. The buccolingual dimension of the bone will always give us a choice what will be the dimension of our implant, okay? From CBCT, we can build the 3D model. Always when we talk about CBCT, remember with me the inaccuracy we might have. Inaccuracy means what? Always when you check your patient's dimensions, for example, the teeth or the gap between teeth or the distance between the arches or whatever, or what point you might check, you always find some inaccuracy, okay, or some disagreement between your patient and the CBCT. So keep in mind this inaccuracy, okay? Regarding the digital scanner, we find always a lot of types nowadays, the intraoral scanners, and of course the extraoral one, which starts before the intraoral one, and now it continues actually with it side by side. Now, from the CBCT, okay, we will always check what to check first, the buccolingual dimension. I will check the available bone. Available bone is a good term, should be always remembered in the implant field. If you read in the contemporary implant dentistry for Carmish, you will find always this term, residual bone or the available bone. Available bone dimensions should be checked first, and we always take care for the, let us say, the buccolingual first. Buccolingual, why? Because it will help us to determine the diameter of the implant which we'll use, okay? Then we might check also the vital structures. We always keep thinking about the maxillary sinus in the upper arch, and the canal, the ID canal in the lower. Also, regarding the vital structures and dimensions, we might check if there's we check the concavities, buccal concavity or lingual concavity. All these points should be checked before I go to the quality and the density of the bone. Density of the bone also might give me some hints regarding the type of implant I should use. We'll talk about within 2 or 3 minutes. Now, regarding the pathologies also, if I have an adjacent tooth with periapical lesion, if there's a cyst, if there's any problem, always should be excluded before we go to further steps regarding the other points. Here's the height, available height or available length I have from the crest of the bone to the canal, okay? And what else I have? Here's the mesodistal dimension between the two teeth, let us say the cemento-enamel junction of this 5 and the 7. Okay, now, what else we might have here? Regarding the digital scanner, I might check the occlusion of the opposing arch, and I might go for virtual wax up to check the dimension of the teeth or the crowns, which I will use later on. Here's the 3 points or the 3 steps now from CBCT, okay, and digital scanner, intraoral or extraoral. Then we might go for the available bone to check the available bone dimensions, vital structures, quality and density of this bone. And you remember with me the 4 types of bone density, if you remember with me, and what else, the pathology, if there's a pathology, and the occlusion. Well, now we will move to the 2 important points, the entrance point and the implant angulation. We keep actually talking about these points always. Check with me this CBCT image. Yeah, first of all, we trace the ID canal first, okay, to keep it in mind as a vital structure. We measured here the mesodistal dimension, okay. What else? The mesodistal dimension was around 12 millimeters, yes, 12 millimeters, 12.5 millimeters. Then we might go for the half of, or the middle of this dimension, which is around 6 point something. From this 6 point something, we will put our line, okay? Here's our line, and we will see now the dimension or the buccolingual dimension of the bone. Now, always when we go for the measuring or placing the implant, or for the implant planning on the CBCT, we always give 1 or 2 millimeters as let us say, as a safe side from the crest. We don't like to have exposure of the threads, although exposure of threads is something we can manage later on, but always we just measure it from the crest 1 or 2 millimeters to avoid the knife edges. Okay, knife edge is something should be avoided. We might remove around 1 millimeter or 0.5 millimeter from the crest. Now, if we measure the buccolingual dimension at this distance, it will be around here 6.5 millimeters. Now, you know that this distance will be enough for an implant with around 4 millimeter. The standard dimension of the implant is 4 millimeter regarding the diameter. Then here we measured the length, the available length from the vital structure, which is the ID canal, till the 2 millimeter beyond the crest. So it was around 12 millimeter. We will have 2 millimeter safety margin from the canal. So this will be around 10 millimeter. For this simple case, we will take, for example, or we will write down the dimensions, the available dimensions for this implant will be 10 by 4 millimeters. Okay. This is not, till now, we haven't placed virtually the implant. We just planned the implant site, okay? We planned our surgery, and we can get some points regarding the entrance point, the implant angulation, and the implant dimension. Now, check with me. Here's the site again. Here's the place, and here's the implant place where I will go for. Now, before going for that point, I have several choices where to place exactly, where to start the drilling. Entrance point, where you will start the drilling point. Here, for example, here, for example, here, for example, where should I go? Okay, in most of the cases, we might go in the midline. Okay, however, I had one of the articles before, this was published in 2010, I think, in JOMI journal. And in this article, we found several types of bone here, as you see, several types of bone shapes or morphologies. Okay, this one, for example, around 65% of the cases, it was like this triangular in shape, where the base is wider than the crest. Okay, and it is considered as the safest one. This is very important point. The second one, when I have a buccal concavity, be careful regarding the buccal concavity here. And the third one, we have, sorry, but this is angled buccally. And this one with buccal, lingual angulation. Later on in Jordan here, with one of my students, we studied more than 700 patients, okay? And we found so many different types, as you can see here, okay? We measured, we took the CT scan, the buccolingual dimension, and the shape of morphology of the bone at the first molar tooth, at the mental foramen, and the first premolar tooth, at the fourth, okay? And we found so many different types. We actually summarized them here, okay? So we have to be careful regarding the buccal concavity here and the lingual concavity here. This one, for example, angled towards the lingual side. This one is the safest, as we said before. I'm not sure about this one. It is rare actually, and this one also might be safe. What I want to say here regarding this point is that we always check the wall morphology of the bone in order to avoid accidents. Okay, be careful not to have accidents with your patient, and we always have to go for smaller dimensions for implants with smaller dimensions, not to go with longer dimensions or longer angulation. So we might have injury here or perforation of the buccal or lingual bone plates. This might cause a lot of problems for our career or our patients, and we have to be very this. Yeah. What else I have here? Here. Yes, we manage this one, and here. Yeah. Actually, we said regarding the CBCT, we checked the available bone now. We checked the dimensions. We checked the vital structures. Yes. And the quality of the bone. I have dense bone here, for example, and I have cortical and dense bone here, for example. Okay. Now I have to insert my implant, for example, from the midline. Okay. However, if you don't consider the opposing arch, we will have always a problem regarding the direction of the implant. So in this case, we would like to follow the Karl-Misch points, the implant protected occlusion, and regarding what we call as prosthetically driven implant placement. Prosthetically driven implant placement, in which you have to consider the opposing arch. So in this way, yes, this is the implant. I will insert the implant in this way. So it will have some, or let us say, buccally directed, few millimeters just to the buccal side, and we will go from the midline here. Okay. Yeah, so this is what we call a virtual placement. Let us go for the virtual placement. Here you can use any software, even the CBCT software themselves. Very simple thing. I measured the 2 millimeter from the crest. I measured the buccolingual dimension. I measured the available bone height here from the crest to the canal, 12 millimeters. So I have 10 millimeter. Then I inserted my implant virtually in this case. Okay, and it was vertically inserted. Vertical insertion of the implant, in this case, I might have some contact here. This will cause what we call, if you remember with me, the bicortical fixation. We don't like the bicortical fixation, actually. Why? Because some reported studies or some reports in the literature, they said that we might have fracture of the implant if you fix it in this way, bicortical, especially in the lower arch. I have some kind of deformation in the mandible. So we just would like to move it just a little bit towards the buccal side, keeping the entrance point here at the middle, okay? And just a few let's say, degrees towards the buccal. This will be ideal. So the central fossa will go directly to the functional cusp of opposing arch. This can be considered as prosthetically driven implant placement. Okay, now, and this is considered to be virtual implant placement. Now, till now, we just placed the implant virtually at the site, and we just did some planning for that. Also, I have to check the mesodistal. Here's the insertion, vertical insertion of the implant, and you can see it is maybe not parallel with any of the teeth. Okay, if I insert it in this way, I will have always a very huge triangle here. Okay. Foot impaction later on. I will face it here, distally with the 7. So I have to manage it with some angle towards the distal side. So this might be a good angulation to go with. Okay. All this is considered as a virtual implant placement. Very simple, very easy thing. And just with some training, you might master it. Nowadays, there are actually so many softwares. Some of them are free, some of them comes with the CBCT machine, some of them you have to take some courses, but in all cases, we think that as a dentist, you have a very high IQ level, so you might go for any software. Here's one of the work we did before. Actually, this patient wants to have his tooth, or this tooth, the lateral incisor, should be extracted actually. So we try to insert the implant in this way, virtual implant placement, planning before even the extraction. In this case, we found here, I might have some exposure of my threads, and it was clear here, for example, and here also, some of the threads would be exposed. So what we did, simply, we just changed the direction of the implant. the angle of the implant just go inside palatally. Okay, so in fact, all of our teeth in the upper arch, they comes in this way. Okay, so they all of our teeth actually, or our implants, the future implants should be directing this way, So in this case, when we inserted the implant palatally a few degrees, so around 10 or 11 degrees, according to Chan 2017. So here we don't have any exposure in the buccal concavity. This is the risk area. Okay, this very simple example of the very simple point should be always considered. Remember with me these steps again. Okay, remember with me the orange points where we took the decision, the entrance point where I will start drilling my point, the implant angulation, I should go palatally more or buccally more or mesially or distally, and you can decide it actually even if when you start drilling for the patient, but we like to do it virtually before taking any risk for these problems. Okay, what else I have? Virtual placement and surgical guide. This is another point. So where can I where can I put this, the implant design point? I can, or I might add it here with the decision points here, the implant design. Oh, there. I like always to use this slide actually, in which Lister, the Inspector Lister, yeah, I don't know if you read the casebook of Sherlock Holmes, he used always to mention that Inspector Lister has a very, very, very excellent skills. When Dr. Watson asked him, what skills do you think he has? He said he's like a doctor and dentist. He has an extensive knowledge, he has a critical eye, and his ability to link and analyze these points together. Okay, so actually, you as a dentist, you have to think with me in this way. You have to look for the available bone in the CBCT. You have to look for concavities or the boundaries of the bone. You have to look for the vital structures and pathologies, and then decide where to insert your implant first. And you can think about the design as a second point and very simple point. In fact, we have, before starting with the design point, we have so many implant designs. If you follow the WIPO websites, World Intellectual Property Organization, and it says the implant or patent registration worldwide, we have more than 10,000 implant patents every year. Imagine with me, more than 10,000 patents registered in the implant field. And I think it might be your chance nowadays to go for implant or patent registration in this field. Here's the implant, first of all, yeah, and I have here the implant, I have the implant body, the fixture, we will call it, we have so many terms for this. This is the abutment, and this is the abutment screw, okay? We will forget about the prosthetic part, we forget about the abutment screw and the abutment, and we'll concentrate only on the implant itself, on the implant body, on the fixture. Now, actually, we have around 10 points should be considered when we talk about the design. Around 10 points, starting from the bone or tissue level, the neck design, the body design itself, the apical thread design, the threads themselves, the shape of the threads, and of course, we will talk about, this is maybe another session, the surface treatment, yeah, and the type of connection between the implant and abutment, and the material themselves, okay, and the dimensions. These are 10 points. But today we will talk about only the fixture design, so it will be regarding these 6 points. And here's so many types of fixtures, as we said. Look with me, this is an implant. Yes, this is an implant, yeah. And this is the thread of the implant thread, yes. And this is the apex of the implant, yeah. This is the apical thread, this is the body, okay, and this is the neck area. Again, we will talk about them step by step. Now here, for example, this is considered to be as a bone level implant, while this is tissue level implant in this way. This is the bone level implant inserted completely in the bone. All this surface is treated and rough surface, acid etching or other type of surface treatment. So it is inside the bone, 100% inside the bone. Okay, we don't like to have any part exposed to the oral cavity because of the bacterial infection and the plaque accumulation and the implantitis and many other factors. So what about the tissue level implant?
this part should be polished, should be smooth, okay? Because tissue level implant, this part will attach to the mucosa, to the gingiva. Look with this is bone level implants, yeah, rough surface. This is also bone level implant. This one also bone level implant, and this also bone level implant, okay? This is number one. Number two here, the tissue level. Tissue level, I have polished surface, as we said, and polished surface always minimizes the bacterial attachment and the plaque accumulation to the surface. What else I have here? For example, check with me, this is grayish in color. Grayish in color means it's rough. So this is the area should be inserted in the bone. And this area should be always above the bone. Yeah, this is tissue level, and this is the bone level. Keep in mind, please. And here again, this is the tissue level flushed with the bone, and this is the tissue level above the bone to serve for the attachment of the abutment and other parts. Second point we should check for the implant design is the neck. We have three basic, let us say, neck designs. The first is the microthreads. Microthreads was introduced, if you remember with me, from, I think, Stig Hansson, 1999. 1999, he mentioned that it is as a retention element, okay? The neck design, when it has this microthreads, actually, it increases the compressive force and it reduces the shear force. Shear force is always very, very bad for our bone. Shearing force always causes direct resorption of the bone and immediate resorption of the bone, according to Frost. If you remember Frost and his mechanostat theory, no need to talk about it now. Now, this is neck design. We talked about the microthreads. The second type is the microgrooves. Microgrooves, till now, we don't have, let us say, a good reports about it in the literature. And most of them say it is very, very close to the microthreads, but actually, finite element studies did not find any advantage for microgrooves. Okay. The third part is the rough surface, but it is non-threaded. Non-threaded, but it is a rough surface. Okay, in this one, this is not polished surface. This is rough surface, but there's no macro threads, no microthreads, no microgrooves at all. Okay, and actually we prefer, in, let us say, this type. Although the microthreads is better for the favorable loading of the bone, but this one actually prevents the accumulation of a plaque and the peri-implantitis later on. We like this one actually. We'll go for the next one, which is this is a study published in 2011, yes, regarding how the microthreads changes, or let us say redirect the forces and change the forces from the shear force to the compressive force. Please check it. And if anybody asks for it, I will send him this one. Now, also this one, is it? We said about microthreads here, microgrooves here, non-threaded in this one. What about this one? This is, we said tissue level, yes? The three ones are bone level, but this is tissue level, and the threads started immediately from the highest point when it attached to the bone. This is macro thread, okay? None of the implant designs now have this feature in which I have macro thread starts immediately at the crest. We always have this type now, all micro threads or micro grooves. This is an old design from what we used to call the brainmark design, okay? Right. Go for the another one. The second one is the body design. The body design, I have to check the taperness of the body. We like always to have our implants to have some parallel sides, okay, at the neck area and part of the body. Then we go for the taperness at the apical third. This one, for example, the neck area just parallel. Then most of it is tapered. Okay, so this body is tapered. What about this one? Also tapered, but with little taperness more than this one. Okay. Now check with me this one. This is a new design from the one of the best companies in the world, actually. But I have a very important point, which is the spirally groove. Here I have a groove, and here also I have a groove, shorter groove. Here longer groove actually. This groove actually comes from what they say as anti-rotational groove. They think actually this groove increases the primary stability when you first insert your implant. Yes, and we do agree for this. But later on, after osseointegration, I don't have any effect for this groove. Okay. Keep in mind, please, the purpose of the implant designs comes just in 3 points. The first one is the ease of insertion. When I have design allows me to easily insert my implant, this is number 1. Number 2, it should give me a very high primary stability. Okay, this is number 2. Number 3, the implant design also should serve for what we call as favorable loading. Okay, later on, after osseointegration, I will not have any benefit of this groove or this groove. But this spiral groove, actually, it allows for huge amount of blood supply for the bone, which comes in the very deep bottom of the thread here. Okay, and this is very important point. Yeah, spiral groove is important and very good. We don't have any problem with this one. But this one, we don't have any positive effect for it, or for the loading or for the bone vitality later on. What else regarding the apical third? This is apical third flat, and this one also flat with aggressive thread. Here, this one. This one has a rounded apex. Yeah. Check with me if I'm very close to one of the vital structures, or I'm raising the or lifting the sinus. Which one will be okay for me? Is it this aggressive thread? No, I should use this one. Okay, when the apex is rounded. Now, the apical third, this one, for example, this has tapered apical third. Why? For ease of insertion. This one also is tapered with anterior groove here and anterior groove here also. This one, I don't have anterior groove, but I have the apical third is parallel. Okay, so this will be difficult to be inserted, although this is one of the best companies in the world, but it will be difficult to be inserted in an easy way. Okay, now, what else I have regarding the apex? This is an aggressive thread. This is a rounded apex, and this is flat. Okay, when as I said before, I'm close to the sinus or to buccal concavity or lingual concavity, be careful, we should use one like this. Okay, never ever go for the aggressive thread or even a flat one. Okay, flat apex might cause some damage. When we use the flat apex, actually we use it mostly when I have short implant and wide implant. So it will prevent the rotational movement of the implant. Okay, this one can be used actually, but I can use it only in the extraction socket. This one in the extraction socket will be perfect. This one might be for the sinus. Now we will check the sinus and these things. Last point in this design points is the thread design. Thread design, this is the square shape, yes, supported by Carl Mesh before actually, and he mentioned that it gives a huge amount of compressive force. Then we have the V shape, yes, and buttress and reverse buttress types, and we have the modified in which the upper flank is a little bit shorter than the lower flank. When I have the upper flank shorter than lower flank, then, shorter than lower flank gives me more compressive, and the upper gives me less shear. And so we prefer this type of design. Okay. Keep in mind, this should be discussed, or this should be actually taken into consideration when you have a difficult case. Yeah, most simple cases where you have a lot of bone, we don't take care for the implant design and we don't look for these points. For example, here's the thread. Again, this is considered to be lower flank. This is upper flank. This is the top or crest of the thread. This is the valley or the bottom of the thread. Okay. Now, there are many points should be considered regarding the thread design. We don't like the aggressive thread. Aggressive thread, we will check some of them now. Check with me. This is considered to be aggressive thread. Okay, deep thread. Okay. Now, where's the retention element in this implant? Implant P, I have most of the retention comes from the aggressive threads at the apical part, apical third, for example. So this might be good for the extraction socket or immediate implant replacement. If you extract your implant, the tooth, and insert this implant immediately, I will have a very high, let us say, primary stability for this implant. This one also, I have the upper flank comes in the rounded way to decrease the shear. okay? But the thread is considered to be aggressive. We have to be careful regarding this one. If I'm close to the sinus or close to vital structure, I might cause damage or do any problems. So what else I have here? This is rounded apex. Yes, this is a flat apex. Okay, and this is also rounded apex. I'll go through some points here. Yeah. Regarding this hole, I don't have, nowadays, we don't have any implant with this hole. Okay, they found it has no, let us say, retention or cannot provide any positive points for me. Okay, what this one, this one, this one, this one, this is the, what we said, the spiral groove. Okay, this one, yes, what else? Yeah, let us just take one or two examples before ending this seminar. This is a case for the sinus. This is the palatal side, and this is the buccal side. And this patient comes for implant placement at this side. Okay, I have enough dimension around 10 millimeters, so I might use, let us say, short implant and wide implant. It will be okay. Now, which implant I can use? Let us give this point. I have around 5 millimeter implant regarding the thickness of the cortical between the two cortical bones here. Okay, I have around 5 millimeters. So which one will be better to be used here? This one or this one? Okay, if I use this one to lift the sinus here, I might cause damage to the ciliary membrane here. Okay, so I might use this one, will be better. However, if I have wide neck, okay, and tissue level, it will be actually the best for this side. Okay, and by this, I might choose this one for my implant for this side. However, if this case comes to my clinic, you might use anyone. In fact, just keep in mind all what we think about, all what we said now is just to think about the implant design when you have, let us say, critical points. Most of the implants worldwide have a success rate more than 95%. Yeah. So I'm thinking about the design of the implant when I have failure of the implants. If you have unexplained failure in your clinic, you might think about the design. Other than that, you might choose your implant design as you like. If you have enough amount of bone, then always keep in mind just to take care regarding the vital structures and the dimensions of the bone, and that's all. CBCT is mandatory in all cases, and keep in mind this line for the virtual implant planning. And that's all for this seminar. If you have anybody question, please.
Thank you so much, Dr. Malik. I personally like it because you went through different aspects that is very important for dentists who are planning to insert implants. And it's good that you mentioned about different software and steps that based on how to work from the beginning using the CBCT with the different softwares, going to the actual planning for insert the implants. And through that, you went through different steps and important steps to plan the implant virtually. And then you move it to another important aspects, which is the implant design. And especially for the critical cases that when we have no enough bone or other issues that facing the practitioner. So thank you so much. We really enjoyed the lecture. So attendees, once again, I would like to thank you to join us for this inspiring lecture. So I think we have one question from Dr. Furqan. If we are using tissue level implant, the level of implant should be at the crest, subcrystal level. At tissue level, the smooth surface should be submargined in the crystal bone. So this is his question.
Yeah, okay. Thank you, Dr. Furqan, for your question. Regarding the tissue level implant, keep in mind there's a polished surface. We don't like to use the word smooth surface. Smooth sometimes means non-threaded, but it is rough. Okay, they like to use polished surface, mirror-like surface. Mirror-like surface or polished surface should be always above the bone. Okay, above the crest of the bone, because this polished surface should be in direct contact with the mucosa or the gingiva, where hemidesmosomes will form and they will start to make the seat around the implant. If the polished surface is placed, let us say, subcristal, we might not have a good osseointegration at that site. Although the implants inserted by Brenmar in the late 60s, okay, were polished. Okay, the current concepts now, rough surface should be always in direct contact with the bone, whilst the polished surface should be always above the bone. Okay, hope it is okay for this year.
Yeah, thank you so much, Dr. Malik. If there's any other questions, please don't hesitate to write them down, so Dr. Malik will answer them. Dr. Malik, you know that many dental implants company are producing different designs as different implants, and sometimes it's very difficult for the practitioner to choose those kind of implants. So have you think about something digitally to choose the implant? I mean, artificial intelligence, by the help of artificial intelligence. Have you come across this? Or if you can touch on that one.
This is a hot topic, Dr. Mahmoud. Thank you so much for this question. CBCT, let us say, softwares and virtual placement softwares are working on this point, actually. Many of my colleagues, actually, even here in Jordan, some of them developing softwares for this point, just to choose the implant, the implant shape or the implant company itself. In fact, I always like to keep the decision in the dentist's hand. Never ever give the company to choose for you or anybody chooses for you. You can just know the principles and choose your implant type according to your knowledge, or you might ask somebody, but never ever follow somebody to tell you which type to use.
Yeah, I think you're right, and this webinar actually give great hints for the dentist to or a guide to them to choose their implants in the future in terms of planning and inserting the or the design of the implant. So I think the attendees are a little bit shy to write some questions. Oh, another questions here from Dr. Nafis. If an implant fall down before the prosthesis setup, what to do? Patient doesn't have any medical disorder or smoke habit.
Yes, thank you, Dr. Nafis. Nafisuddin actually is my sensei in Tokyo. He's my friend and colleague. Dr. Nafis is asking about if the implant fall down. So this is a failure of the implant. Okay, when I have mobility of the implant should be always taken out. Now, before prosthesis setup, you are lucky to have the implant failed before you actually put the prosthesis. And in this case, complication will be more and more. In this case, actually, if I will take a radiograph first, I will check if there's an infection in the area, if there's pus or abscess around. If there's no pus or no abscess, the failure might be because of mechanical factors. Mechanical factors like if the patient keep or have some habits to push around the area, so I don't have I have some type of micromotion. Micromotion leads to implant failure. Okay, so in this case, I just clean the area, make some irrigation, and insert another implant immediately in the site as an I will consider it as actually as immediate placement of the implant after extraction. Okay, in case you have pus or infection in the site, just clean it, make some irrigation, and postpone the patient till 2 weeks to check again.
Very good. Any more questions? Don't shy, don't hesitate to write, please. It's a great chance that Dr. Malik with us today. Try to take this chance and ask questions. I think with that, we are going to conclude our webinar today. But before to do that, it's Digitodontics tradition to present a certificate of appreciation. So hereby, we express our sincere appreciation to Dr. Malik Hudieb in recognition of his contributions as a live webinar speaker for the Digitodontics webinar series on the topic of Virtual Dental Implant Planning, a tool to select your implant design, that was presented on Tuesday, September 27, 2022. So once again,
thank you so much.
I really appreciate your time to be with us. And actually, Dr. Omar, thanking you for this great lecture. So once again, Dr. Malik Hudieb, we are so glad to having you with us today to share with us your experience in this field. So thank you everyone to attending this webinar today. And I will take this chance to let you know that we have several webinars are coming in the few coming weeks. So don't hesitate to come again and be with us to see all these digital related webinars that will reach your knowledge about digital dentistry. Once again, Dr. Malik, thank you. Thank you so much.
You're welcome.
Jazakallah khair.
Well, yeah, thank you so much.
Assalamu alaikum.
Thank you so much.